This is QD Clinic, and I'm Dr. Jack Cush from RheumNow.com. QD Clinic is brought to you by RheumNow.live, where every seat is a great seat at RheumNow. Our case this week is inflammatory hips. Just saw this case a few days ago. 49-year-old white female comes into clinic with a 5-year history of bilateral hip pain. You know, it's the kind of hip pain that's actually hip pain. It's in the groin. It hurts when she does stairs. This is not really low back pain. She's got a little low back pain. She's got a little spondylosis of her lumbar spine, but that's not her major problem. Her major problem is last 5 years, her hips in the groins have been hurting, and it's been getting a little worse. She has no other history, little hypertension, takes very few medicines, has been tried on 2 different nonsteroidals with no benefit at all. She has some labs done, no evidence of inflammation, sed rate, CRP are normal, no serologies were done, x-rays were done, and very interesting. She showed bilateral concentric loss of joint space. Superiorly, on the acetabulum, there's some sclerosis. Beneath the femoral head, there's some ring osteophytes, but there is this sort of, again, concentric uniform loss of joint space in both hips. The question is then, what's her diagnosis and how are we going to treat this? So the real issue here, I think, boils down to the x-ray findings. She has no other features to suggest another arthropathy, other inflammatory arthropathy, or spondyloarthropathy. If this were rheumatoid arthritis, there would be that concentric uniform loss of joint space. And there was no obvious evidence of erosions, but there was some irregularities that I'll bet if we had an MRI, there might be erosions there. But that doesn't help you if you're looking at spondyloarthritis versus RA. They could both give you erosions. And so the question then is, what other clues do we have? In rheumatoid arthritis, you have this uniform loss of joint space without any reactive bone. In patients who have spondyloarthropathy, there may be sclerosis and there may be osteophytes. That is also seen, by the way, also in pseudo-gout. So turns out that that's probably the more likely diagnosis here, that it's a spondyloarthropathy and or pseudo-gout. Now, how likely is a spondyloarthropathy, ankylosing spondylitis, to show up? By the way, her SI joints are totally normal, at least by x-ray. You know, MRI might show something different. But how likely is the spondyloarthritis to show up at age 40 in a woman? Well, we do know women don't present as men do with spondyloarthritis. They present much later in life. Pain is a big issue, and function can be a big issue. So this is certainly within the realm of possibility for a spondyloarthropathy. RA, there's no evidence peripherally of anything as far as a symmetric synovitis. So that's our differential. This is spondyloarthritis first. This could be infection second, TB, brucellosis. We're here in Texas, unpasteurized milk from Mexico, either in the form of milk or milk products and cheeses, could lead to brucellosis of the spine and or hips. And then lastly, I guess CPPD. So we were going to get other x-rays to look for CPPD. We were going to get an HLA-B27. And then we're going to treat the patient. The question is, how do you treat her? She's been on nonsteroidals, no benefit. What if you gave her intra-articular steroids? That would help if this were inflammatory OA of the hip or an osteoarthritic or degenerative process. May not help very much if it's a spondyloarthritis, and we don't think this is rheumatoid at this point. You could just give her an empiric trial of a TNF inhibitor. We did that. We'll wait and see what the labs show and what her response to therapy shows. We'll know within 2, 3, 4 injections whether that's the right thing to do or not. If not, we'll worry about pseudo-gout and chondrocalcinosis and look for evidence of calcium deposition in cartilage elsewhere in the body, although she's not symptomatic in her hips or not in her knees or her wrist. Really interesting case. I thought that you would enjoy that. Really interesting program at RheumNow. I should just show you what's on our autoinflammatory session, which is going to be on Sunday morning. We have some giants speaking at this session. Hal Hoffman from UCSD basically invented the inflammasome and is world renowned for his work in autoinflammatory disease and familial cold autoinflammatory syndrome. Dan Kastner from the NIH, is going to talk about how they work up and evaluate patients with febrile disorders. And then Nicola Dalbeth from New Zealand, Auckland, New Zealand, is going to talk about gout as an autoinflammatory disease. I can't wait for the Q&A session with those three heavyweights. RoomNow.live. Register now.